Hello and welcome to Health Affairs This Week. I am your host, Jeff Byers. We're recording on November 21st, 2024. Before we begin the show, just wanted to give a quick plug for everyone to listen to Season 2 of Research and Justice for All. Check our show notes on that. And I definitely saw the news about Dr. Oz being tapped to lead CMS. We are taking a little break for the next 3 weeks where we'll be re-airing a season of our Pathways show from 2023 before a new episode of This Week comes back. And then we're going to take a 2-week break until 2025. Perhaps we will do a deep dive on Dr. Oz and or RFK Jr. when we return. A lot been going on this week, but this week we are here to talk about the Medicare Shared Savings Program. Late last month, HHS released the results from 2023 regarding the MSSP. According to the agency, the program saved more than $2.1 billion in 2023, the largest savings in history. Some may believe, like myself, this is a needed win in the argument for value-based care. Dr. Farzad Mostashari on the platform formerly known as Twitter wrote, "This is unprecedented in the history of Medicare. We have had decades of pilots, programs, payment schemes. This is literally the first time that we can say a payment model saves money while delivering higher quality care at scale nationwide." So, a lot to discuss. And to discuss, I'm joined by Frank McStay from Duke Margolis. Frank, welcome to the program.
Yeah, thanks for having me, Jeff. Like you said, this is a really interesting time to work in value-based care and healthcare with such good results. And so looking forward to the conversation today.
Looking forward to it as well. Looking forward to learning a little bit. So the MSSP has been around for at least 10 years. The $2.1 billion savings is the largest to date. What immediately strikes you from these results in the context of value-based care?
Yeah, so I think, again, like you're saying, like Farzad was saying, like this is incredible results, 10 years in, CMS and really CMMI, but this is a CMS program. But in general, the agency has been trying for over a decade to get lower costs, higher quality care. They've had successes. They've tested a lot of pilots, like Farzad said. But, I think over the past couple of years, but especially this year, we really see kind of the fruits of that labor paying off with, so many billion saved. That's tremendous progress. And I think that progress really points to not just a lot of key core learnings about value-based care and how we've implemented them over time, but that people kind of understand the opportunity here through SSP, that it's getting easier to participate in, that over time, like your savings tend to get better. And so again, like I think the maturation, the maturing of the program, we see that, this is working. And so my immediate kind of thinking is like, again, great results. We see kind of a core group of providers continue to participate and do well. And, that primary care is really important to this value-based care journey we're on.
Yeah. So we had a couple of prepared questions, but I'm going to divert real quick just to quickly ask you. You brought up this idea of core learnings around value-based care. What do you mean by that? What are the core learnings of value-based care?
Yeah, so I think a big part of CMS's efforts, not just now, but historically, is something known as like learning and diffusion. This value-based care idea, this accountable care concept really does turn kind of the traditional delivery system and payment system of healthcare on its head. And so to make sure that people can participate well and find success in this kind of new payment, new delivery scheme, a big part of accountable care is learning, i.e. like changing the way we deliver, transform care. And so part of this is understanding those unique kind of successes in the model, what people are doing and doing well, and how to scale those more broadly. And I think over time, these years, 10 years that this program has been around, CMS has tried to do different things, both in SSP and the fee schedule, and then scale them to SSP to say, oh, we need to change quality measures, or we need to reduce quality measures, or we need to think about different waivers that are part of SSP. Again, like, as we kind of change small things in the program and they seem to either uptick savings or improve quality, like saying, oh, everyone should be doing this. So again, I think one of the key immediate learnings from this is learning is important and it takes a while to get going. But as you kind of develop an understanding of the program and how to participate successfully, scale those.
Yeah, another thing is interesting, like learning how your patient population actually behaves within your actual care delivery model is kind of interesting, and having to learn, what the realities versus wishful thinking of behaviors is.
Very much so. The behaviors of patients, and I think also the behaviors between patients and providers. One of the key things about value based care is that as we kind of pay providers differently, in theory, they're going to have more time with the patient, and we can potentially change that kind of relationship, that dynamic between not just the patient and the provider, but the patient and health system overall. And a key part of that, that linchpin, is primary care. That's a lot of patients still go to the ED, and that's their entry point. But more patients, I think, especially through value based care, are saying, wow, the entry point to the health system for primary care and value based care is a lot better than traditional kind of health system. And so, like you're saying, I think the key, not necessarily learnings from value based care, but this key opportunity through value based care is, again, especially in the context of primary care, that patients kind of can change their behavior and we can change our interactions with patients through value based care.
And so, going back to the report, what might these results highlight regarding financial incentives regarding value based care, especially in the context of primary care for those in the Medicare program?
Yeah, no, I think there are a couple things, especially when we think about primary care. One, I think we've all known, even probably before value-based care, that again, the primary care is the foundation of kind of how you not just access the health system, but how you maintain wellness, and how you maintain your health. So the idea was that value-based care would kind of right-size that primary care opportunity, give it the supports they need, i.e., the financial incentives we need to kind of bolster that kind of primary care, that wellness aspect in the Medicare program. And so I think what we're seeing is as providers especially progress into more advanced models, for example, like most of the participants in SSP are in advanced risk-based models this year. And I think that kind of shows us that the results highlight that when you take on more advanced kind of models, you aggregate that payment and take on risk, that it really does support primary care more. You can do the more longitudinal management of a patient condition, their chronic conditions. You can better kind of articulate what the patient needs and how to meet those needs. And so, again, I think what we're seeing here through SSP is that over time, we've been able to invest enough in primary care. We still have a long ways to go, but we've been able to invest enough in primary care to really, again, pick that low hanging fruit and invest the fruits of our labor.
So, based on the CMS data, 2023 included about 600,000 physicians, about a third of the US workforce across 11 million beneficiaries, with the CMS goal of 100% of traditional Medicare being a part of accountable care relationships and an estimated 67 million Americans to enroll in Medicare the same year. What can we predict about value based care adoption in Medicare given this report?
Yeah, that's a really great question. I think just to cement a few kind of key statistics that you're hitting on, like we're close to 11 million beneficiaries in SSP right now. Out of the, I think, 34 million traditional Medicare beneficiaries, like have that many traditional Medicare beneficiaries, have that many in an SSP, that's a lot. That matches kind of the third of the US physician workforce. And so, again, I think we're kind of at this tipping point necessarily where we've learned a lot and we have enough people in the program and enough of kind of not necessarily the revenue at stake, but the revenue in value based care that we're kind of, again, gaining like this snowballing effect. And it took a while, but we're slowly getting there. And again, lots of progress still left to be made. But I think in terms of what we could predict based on this report is a few things. Obviously, we're still in a transition period. A new administration is coming in, and so we're still kind of trying to figure things out. But I think this underscores that investments in primary care are absolutely necessary. And moreover, like a more advanced primary care kind of system is really important for success in a value based care and accountable care world. We want everyone in an accountable care relationship. It starts kind of with that primary care journey. I think the other thing that we can kind of prognosticate a little bit based on this report and everything is that, again, two-sided at-risk models are really important. We need probably more advanced models, i.e., not just risk models, but again, models that provide more support to primary care and other providers upfront, an aggregation of payments so that way they have the resources they need to be successful in a payment model. And then I think the other thing is we see kind of from this report and others that physicians, those kind of not just primary care, but physician leadership in accountable care is really necessary to make sure that you can be successful.
Yeah, so you mentioned leadership, and I wanted to ask you, what does this say about the business of primary care beyond Medicare in 2023? And I think the focus I'm interested in is, are people becoming primary care physicians? Like, what is the supply of primary care physicians going to be like in the near and far term future, especially when you think about that leadership and, advocating for investment in that area?
Yeah, I think that's a really tough question.
Okay.
We know that the supply, the constraint in this is that there are not enough primary care physicians. The labor market for those physicians is constrained. I was at an event yesterday, the Patient Centered Primary Care Collaborative (PCC), and they released their evidence report highlighting kind of some of the same things in SSP and how primary care is really important for it. And I think recognizing we're in a constrained kind of labor market for primary care, but its importance, there are probably a few things that this means. One, there are other providers, primary care clinicians, who can provide some of these services in a team based environment. There have been other articles published in Health Affairs showing that a primary care team, a team based environment, is really important. We see things that Medicare has done, including reimbursing different types of services and providers to provide these services, is important. And so I think as we kind of go into the future of primary care and accountable care, continuing to broaden our understanding of primary care. The other thing I think I'll say here is getting more knowledgeable about what we mean in primary care. Through no fault of its own, like CMS, like the data set for SSP, the information we have about primary care, it's pretty limited. We don't always know the exact type of clinician delivering these services. We don't necessarily always know the investments they're actually making in primary care through SSP. We just kind of have some proxy measures in some way. Primary care, we don't know if it's necessarily APP or non-physician practitioner. And so I think what CMS has done, through example, through its RFI on Medicare Advantage data and other data elements, I think CMS is really trying to move towards the business of better data collection, which will really help us understand the moves or the policy recommendations that we should be making to help improve primary care.
Thanks for that. And just to give a quick shout out on team-based care, evidence-based research, I immediately thought of the work of Max Pani and Lucy Chen from 2021. There may have been another co-author, so my apologies if I did not mention you. But Max and Lucy came on the Health Podyssey podcast way back in 2021 to talk with Alan Weil about teams working better than solo providers. And it's an interesting episode and research article. And Max had the best sounding microphone that any guest has ever heard. So yeah, just give a quick shout out to that. And so as we wrap up our conversation, so I know you, Frank, are working on a piece for Forefront on this topic. So are there any high level observations that you may want to like dive into the upcoming Forefront piece? Give a little taster, to our audience.
So, yeah, I think there are a couple things that people can look forward to that we're going to continue on from both previous blogs, but also build on. And so I think the first thing I want to highlight is we're going to continue some of our, not deep dive analysis, but some of our pretty basic analyses in terms of overall savings, participation, especially relative to some new things we're looking at in terms of overall participation in SSP relative to MA and kind of the other programs, especially, for example, REACH. The other things we're looking to kind of build on are how are ACOs performing when they have more, for example, like safety net providers, or they serve more underserved populations. The past couple blogs, we've really tried to hit on that and give more information about, those population specific ACO successes. And so we're going to continue to provide that. We'll also be looking at, how ACOs incorporate more specialists or less specialists tend to do. And then we're also going to be focusing on how does the proportion of overall primary care physicians in your kind of ACO organization affect your performance relative to the benchmark? And so we're going to add some longitudinal. We've gone back several years since, I think, 2017 to kind of look at, hey, if you have more primary care physicians in your organization, how does your performance look like you're doing over time? And so that's something we're really looking forward to kind of get everyone's reactions to. Finally, we might be actually doing some analyses on risk scores relative to performance. And so we're excited to kind of see how that analysis bears out and how kind of ACO performance is thought of when we think about things like riskier populations, both clinically and socially.
Oh, that all sounds really interesting. Do you know what date that might be going live?
Our goal is actually to submit it right after this podcast, or probably tomorrow. And so I have to imagine probably a few weeks for editing and everything, but definitely before the end of the year.
Yeah, well, fantastic. Listener, check out Health Affairs Forefront, bookmark it. There's a lot of good stuff that gets published there. And be on the lookout for Frank and colleagues' article. Well, with that, Frank McStay, thank you for joining us today on Health Affairs This Week. This is a great conversation. I think you lent a lot of insights for me and for our listeners. If you, the listener, did find this insightful, please send it to the coupon clipper in your life, for savings, the savings enthusiasts. We'll see you in December. Thanks, and have a great rest of the week.